Good morning. Welcome to the USC Institute of Urology. Welcome to our weekly Urology 60 Minutes program. Our format has been very well received by all our colleagues in the US and internationally. First and foremost, I hope everybody is doing well. You and your families are safe and healthy. Here's hoping that we are getting over the hump here and the plateau and hopefully start getting back to near normal existence. But again, in every challenge, there's an opportunity. And the one here is for us to join hands, learn together. And for that, this morning, we really have an outstanding slate of speakers. The topic is advances in neuromodulation. And we really have the world experts in this topic who are going to be teaching us about this. We have Dr. Michael Kennelly from the University of North Carolina in Charlotte. We have Dr. Kenneth Peters from the William Beaumont School of Medicine in Michigan. And then we have Dr. Howard Goldman, professor of urology in the Department of Urology at the Cleveland Clinic. All of them are good friends and thought leaders to whom we look up to for information and expertise on this topic. The USC host is going to be Dr. Larissa Rodriguez, a professor of urology at the University of Southern California. Larissa is a thought leader in the field, one of our most valued faculty, vice provost for the University of Southern California, and really a dear friend and colleague. I'll pass this over to Dr. Rodriguez now to get us started. Larissa?
Good morning. I'm going to share a screen here. All right. I am so excited to have this section today and have such great friends and colleagues joining me. They really are experts in what they do. Dr. Kennelly is going to start us today talking about contemporary concepts regarding botulinum toxin for refractory OAB. He'll give the first talk. He's an expert and a thought leader in the use of botulinum toxin for bladder symptoms. He's going to be followed by Dr. Peters, who's joining us from Detroit. He's going to be talking about tibial neuromodulation, the past, present, and future. And lastly, we will have Dr. Goldman coming from the Cleveland Clinic to talk about advances of sacral neuromodulation and the controversial use of MRI with neuromodulation. If we have time right after that, we will have two of our esteemed colleagues in our department at USC. It's not Dr. Kennelly, but I'm sorry I put that in his slide. It's Dr. Ginsberg on the left and Dr. Creighton. And they will do a panel discussion to have the experts that are visiting us today give us their opinion as to how to manage symptoms that have difficult neuromodulation issues. So with no further delay, we'll have Dr. Kennelly start us out.
All right, well, good morning, everyone from the Charlotte area. I hope that everyone is actually doing well out on Southern California. It's certainly a pleasure to be here. And I'd like to thank Dr. Gill and Dr. Rodriguez for inviting me to be part of this. What I'd like to do probably for the next time is kind of focus things into three different areas. One is kind of talking about some of the newer pathways regarding botulinum toxin, a little bit about efficacy data, but spend most of the time talking about different aspects regarding techniques of injection. And for this, the disclosures you can see, pertinent for me, I do a lot of research and studies and consultant both for Allergan and also Ipsen regarding neuromodulation and botulinum toxin use. So setting the stage of the framework, you know, back in the late 1850s, Clostridium botulinum was first identified. And it is an anaerobic gram-positive rod that releases the toxin. And over the years, we've actually now identified 7 different strains of botulinum toxin, types A through G. Now, each of them have unique different properties, and only types A and B are commercially available at this time. But in general, we know the concept. Basically, the toxin gets taken up by the presynaptic nerve terminal, then through its evaluation cleaves the snare complex, making inability for acetylcholine to be released. And the last is usually temporary, only about 3 to 6 months. Now there's currently 16 indications for botulinum toxin use throughout the world, so there's a variety of areas that it's really improved upon. If you look to the right, really the neurotoxin itself is 150 kilodalton, and it has a light chain and a heavy chain. The light chain is actually the most active component, whereas the heavy chain is just sort of a receptor location. It has 2 disulfide bonds that sort of control it together. And the mechanism action, at least that's been proposed, is that when you inject it within the detrusor area, the heavy chain actually has the receptor onto the presynaptic cleft. And that heavy chain will bind. It then endocytoses in. With the pH of 6, you'll get a release of the disulfide bond. The heavy chain inserts itself into the basement membrane, and the light chain moves out into the cytoplasm. At that point in time, based on the toxin, it'll either cleave SNAP25 or synaptobrevin. And based on that, it inhibits the release of the neurotransmitters into the synaptic cleft, and for our purposes would be acetylcholine. Now remember, there's many different neurotransmitters inside that vesicle. Now if you look at things commercially, we have sort of 4 toxins that are on the market, but there are 3 that are type A, and they're uniquely different. And the reason they're uniquely different is because they have different units of activity. A unit of activity of toxin is based on the LD50 of a mouse, and based on each company has a different reagent. That's why they cannot sort of, a unit cannot be equilibrated to each unit that's there. Now, research has shown us clearly from urodynamics that we definitely have a decrease of detrusor overactivity that occurs. We have a decrease in the amplitude of involuntary contractions, bladder capacity have increased, compliance has improved, and urge symptoms have improved. But when you really look at it, remember they were telling us that it's an efferent component, basically a release at the detrusor area. But that can really only explain the ability of decreasing the amplitude of detrusor contractions or the lack of detrusor contractility. But remember, we're also seeing symptoms of increasing bladder capacity. We're actually seeing improved compliance and a decrease of urinary urgency. And these are really more along the afferent side of aspects. And so this is what I wanted to bring up and remember is that emerging evidence has really shown that it's really the sensory and urothelium aspects of botulinum toxin that has probably improved its use. And if you look at the description here, we have the urothelium, the umbrella cells, you have the suburothelium where the efferent and afferent nerves are located, and then the detrusor at the bottom. Based on the urothelium and its physiochemical and thermal and properties, as it enlarges, it's releasing neurotransmitters, mainly ATP, nitric oxide, and acetylcholine. And as it releases these, it can affect in the suburothelial area. And it's been shown that with using botulinum toxin, there's actually a decreased release of ATP and substance P at the urothelium. The receptors of P2X3 and TRPV1 receptors have decreased, which are instrumental in sort of pain thresholds, and you get a decrease in acetylcholine. On the suburothelial layer at the myofibroblast layer, you too get a decrease in receptors that are mainly affecting the afferent nerves, in addition to that traditional blockade on the efferent aspect. And so in general, what the concept I want to portray is that really there's a 3-layered mechanism that's going on. You get probably the original layer, which is at the urothelium, decreasing ATP. The second effect gets on the afferent nerve activity, and then the longer effect is really the detrusor muscle. And so there's a quick effect that we've seen, and then more of a long-term aspect. So it's not just the efferent component, it's the afferent. Sort of switching gears, I'd like to touch base a little bit on efficacy. And this botulinum toxin has actually been one of the most studied agents in the OAB field, and it has grade level evidence. This is from the phase 3 trial data. Both on the top is overactive bladder, on the bottom is neurogenic detrusor activity. You can see there's different dosages, 100 for OAB, 200 for neurogenic. But what you're seeing consistently is the decrease in urge incontinence. Traditionally, about 30 to 35% for OAB and around 30% for neurogenic. And if you have an OAB patient, roughly up to 31% of patients became dry during the trials, when the average was about 5.5 leakage episodes per day. And in the neurogenic trials, up to 38% of neurogenic patients became dry that had weekly leakage episodes of around 23 leaks per day. In addition, various different long-term trials have shown consistency, that those results are consistent throughout. They don't tend to taper off. There's no tachyphylaxis. For the OAB area, the results tend to last roughly a median around 7.6 months. And that can be variable based on a lot of factors. And I think the issue regarding incomplete bladder emptying has always been addressed. You can see here the adverse event profiles for both the OAB on the left and the NDO on the right. Urinary tract infections are still a higher risk than using this technology. So typically 18% for OAB and 24% for NDO. But incomplete bladder emptying, or the need for catheterization, was strictly defined in the trials for OAB. Basically, if you had a PVR greater than 350, you had to catheterize. If you had obstructive symptoms with 200 to 350 PVR, you needed to catheterize. And those results showed in the OAB trials were roughly 6%. The neurogenic trial, as far as catheterization, was really left to the principal investigator. But what many different meta-analyses have shown is that I think we can clearly say, based on grade 8 evidence, that botulinumtoxin can decrease urinary incontinence. In fact, roughly 30% of OAB patients can be dry. The UTIs are nearly 20%, and the risk of catheterization is around 8%. So there's always good and bad that goes on. Within the last time, what I'd like to do is really focus more in on injection templates and sort of injection techniques. Now, based on the trials, this was the data. For OAB, you used 100 units in 10 mLs. You did 20 injections of 0.5 mLs aliquots. For neurogenic, it was actually larger dose, 200 units, in a larger volume, 30 mLs, and you did 1 ml injections distributed throughout the bladder. The key was it was supposed to be non-trigonal, 1 centimeter apart, and about 2 millimeters deep. Remember, a normal bladder is roughly 6 millimeters, so that was the focus. But remember, there's a lot of variables with this technology, and the variables that you can see here: dose, location, number of injections, dilution. And so I want to spend a little bit of time just talking about those variabilities. Some of this is just going to be concepts because we don't have everything set in clear evidence. But something you do need to know is that there clearly is a dose-response relationship regarding dose. Specifically in the dose ranging trials of the phase 2 study, you can see that as you go up, the efficacy as far as increased bladder capacity goes up. But the caveat is that posterior residuals also rise. So at 200 units, it's roughly 30% of patients who have an elevated PVRs greater than 200, whereas with the 100 unit dose, it was around 15%. So the benefit here is that, remember, you can actually go lower dose and still get some effect, and you can also get higher dose and get possibly a better effect, but you risk incomplete bladder emptying. Well, let's look about location. One of the things that intrigued me in a rainy day in the Carolinas was this is the actual template that was described during the phase 3 trial. Basically, 20 injections, 1 centimeter apart, is roughly a 50-cent piece. And the neurogenic trial, 30 injection, is roughly 3/4 of a business card. And I thought to myself, well, boy, that's a small portion. When you look at it based on the volume you put in the bladder for injections, that can be roughly about 1/5 of the area. And so the concept that I was thinking about was, well, what about, that's a local injection, but if you have a neurogenic patient and you're trying to really shut the bladder down, should you use a diffuse type of template? And those are just some theories to kind of think about. The other area that people looked at was, well, we know there's different types of injections. You can do intradetrusor up here on the right, where you see it's in the muscle, and as you inject it, it diffuses through, versus on the upper left, you're seeing a suburothelial where you put the needle in, you lift the urothelium, and you create this bleb. Now back to the physiology and mechanism of action, you can see a suburothelial actually is trying to get to the sensory nerves based on a lot of the testing, whereas the detrusor may be trying to get at the efferent motor nerves. One thing that I will say is doing a suburothelial injection, it tends to have diffusion of the toxin out a little bit more. In addition, it tends to bleed because there's not as much resistance around that area. So the other area that we looked at was, what about the trigone? Will that cause reflux? Well, Carcenti actually injected 200 units solely into the trigone of 11 OAB female patients. He studied them video urodynamically before and at 6 weeks afterwards, and lo and behold, no one had vesicoureteral reflux. The one thing he did notice is only about 36% of patients had improvement of symptoms, but the study wasn't really designed specifically based on symptoms. So Ko, actually out of Korea, looked at this. He tried to stratify in a small observation study where he looked at 15 patients in each arm, Detrusor injections, suburothelial injections, and then bladder base injections. In the upper right, you're seeing his template for bladder base. Basically, he used 5 mLs, injecting 0.5 ml aliquots, 5 into the trigone, 5 in the peri region. And you can see based on a 3-month evaluation, which is very not sort of set standard objective evidence, that the bladder base had improvement, but it did not seem to improve bladder capacity. And so some people have thought potentially this could be best for patients with detrusor hyperreflexia and impaired contractility. Well, what about the number of injections? You know, it's been said 30 injections versus 100. And the data on this, once again, is not clear, but this was an interesting study that was out of Switzerland. They basically mixed up within the infusate gadapentate solution and did MRIs on 6 patients right after they did injections. They used 30 injections and 30 mLs for one template, 10 injections and 10 mLs in the other. And what they found was basically with a 30 ml injection, you're only getting about a third of the bladder that has the toxin. Whereas in 10 injections, it's 25%. So this is still using more of a localized template. But interesting here, they also noted, is that nearly 18% of the toxin was actually outside the detrusor. They theorized that this was possibly related to the thinness of the wall thickness, and it was mainly due to potentially the needle going outside. So this brings up the point of really how your needle is placed, the depth of location is really key, because if 20% of the medicine is not even delivered to the area, we're not getting as good of effect. The last area I'd like to talk about is really dilution volume. So most of the injections are done with 0.5 or 1 ml. And in my experience, the 1 ml has several advantages. One, you can have a better chance for correct placement. As you're injecting it, if you're in the wrong location, you can readjust the needle and still deliver the volume. You're certainly using that volume to spread the toxin out into a more wider distribution. You can see better when you inject it. Are you in the right spot? Does it elevate? And it allows the toxin to spread. On the flip side, a smaller aliquot is quicker. You have less syringes to use. And it definitely is less painful because it's actually the spread and the push of the toxin into the muscle that patients find it. But the negative side is there's actually a higher chance of surgeon error. So the last part I want to quickly go through is recently there was a randomized multicenter controlled trial that looked at a new injection paradigm. Basically, they looked at the location sticking strictly to the peritrigonal region, decreasing the injections to 10, and the dilution volume was a lot less. So this was randomized of OAB patients, 2-to-1 randomization. They did 8 peritrigonal injections, 2 intratrigonal, 0.5 aliquots, 100 units was utilized. They used the same sort of evaluation that was done regarding the original OAB trials. 75 patients were in the injection arm, 40 patients were in the placebo arm. The demographics were the same. You can see here that patients had around 6 leakage episodes per day and were voiding about 10 times per day. Statistically, at each time point that was done, you're seeing about a 50% improvement regarding urge incontinence reduction. At the end of 12 weeks, it was -3 leakage episodes per day. When you looked at that at total dry rate, around 14.3% of patients at 12 weeks were dry compared to 2.7 placebo. There were also statistical significant differences regarding urinary incontinence reduction, frequency, and urgency that was noted. The most interesting aspect here that came out when you looked at adverse events was that urinary tract infections appeared to be higher within this new paradigm. But the interesting part was that the urinary risk of retention was 0 out of 73 patients. And when you compare that to the pooled analysis of all the phase 3 and 4 trials of 5.2%, that's a dramatic difference. So this new paradigm does show a few of the variables that are different. It's nice to know that there is some benefit and you have decreased risk of a need for catheterization, but the UTIs may be higher. So I'm going to leave you with this. This is kind of how I assess and looking for things. I do believe that we do have many variables when we're doing injection technique based on the dose, location, number of injections, dilution. All of these patterns are not really sort of formulated out, but based on some of this, there's a strategy for the certain type of patient factor of what may be utilized. And I'll end it there and turn things back over at this point in time to Dr. Peters.
All right. Thanks, Mike. I'm going to start on my talk. I really want to thank Dr. Gill and his team there for the invitation. It's nice to be able to collaborate like this during this difficult time. I'm, you know, wishing everyone well and health, and hopefully we can get back to some semblance of normal soon. I get to talk about something near and dear to my heart, which is neuromodulation. So I'm very excited about that. The, let's see, maybe. There we go. Conflicts of interest. I do also some work, but the most important one, and I'll highlight this during my talk, is the top one. I am a co-founder and equity owner in a company called Micron Medical that's involved in a tibial nerve implant. So let's talk about the tibial nerve. I mean, percutaneous tibial neuromodulation has been around for quite a while. It is something that is has been studied since the 1980s for the treatment of overactive bladder. It is something that I was always skeptical of. Every study on this early on in the 80s showed that about 75% of patients got better with tibial neuromodulation, but there was never a sham associated with this. And it wasn't until we published our pivotal paper with a sham that we actually got some sham controlled data. What at that time, like I said, I was a skeptic because I did a lot of sacral neuromodulation and didn't see how stimulating the tibial nerve for 30 minutes once a week for 12 weeks could work. And so at Beaumont, we actually developed and validated a sham. We published on that. I actually wrote an NIH grant to try to, and my hypothesis was that PTNS would be no better than sham, and did not get funded. But at the time, there was a company called Uroplasty who had a device that they couldn't sell because they didn't have data, and I had a sham and a protocol, and reached out to them, and to their credit, they went ahead and funded a trial. And this was called the Summit trial. And this was an intent to treat analysis of 23 centers. It was a double-blind, sham-controlled trial. We enrolled 220 patients. The sham essentially was every patient had their eyes covered where they couldn't see what was going on, but we used a Streitberger needle, which is kind of like a collapsible needle, so they felt a poke in their ankle. There was 2 grounding pads put on. You know, for normal PTNS, there's always a grounding pad as part of it, but in the sham, there was actually a TENS unit placed below the small toe, and that TENS unit is what was activated in the sham group, so they could actually feel stimulation. They underwent 12 weekly treatments, 30-minute treatments, just like the typical paradigm, and then the outcomes were compared. For this, we used our primary endpoint of a global response assessment, which is a 7-point scale from, you know, markedly worse to markedly better, and we defined a responder as someone who said they were moderately or markedly improved. We did this based on data we looked at with sacral neuromodulation, as when we looked at the GRA. If somebody said they were moderately or markedly improved, it correlated very well with improvements in voiding diaries and in questionnaires. And also, since this is a syndrome and not everyone had incontinence or frequency and urgency, it really, really captures a lot better how the patient perceives their improvement. And when we did this and we compared overall bladder symptoms to the active treated group, there was about a 55% success rate in those that were getting active treatment, compared to around 21% of sham. And if you add those two together, and that's what we pretty much saw in open label trials. So it correlated pretty well with it. But when we looked at urgency, frequency, and urgent continence, active PTNS beat sham each time. And then, looking at voiding diary parameters, the PTNS group, had a significant reduction in frequency compared to the sham group. Nighttime voids were improved in the active group compared to sham. Moderate to severe urgency improved, and urgent continence improved. And so, this showed exactly what we anticipated, well, some anticipated it would show. I didn't, but this made me a believer because this was a very well-designed trial. The question was, after those 12 weekly treatments, what do you do? And what we did is, for patients who did well and wanted to continue on, we went ahead and did an extension trial that we called the STEP study. And basically, patients were weaned down to, instead of once a week for 12 weeks, then they did every other week, and then they did every third week, and then ultimately they had a personalized treatment plan where we just asked them to basically let us know when they needed to be treated again. And what we found is that it took about one treatment a month over 36 months to maintain benefit. Now, some people needed it sooner, some later, but this is why the insurance company pays for 12 weekly and once a month because of this data. The other thing is over time, obviously, with a 36-month study, you lose patients in a clinical trial over time. So we use the last observation carried forward analysis. And what we found is that for frequency, you saw a reduction in frequency in that first 12 weeks, and then a sustained benefit over 3 years. Urgent continence, the same. Nighttime voids, moderate to severe urgency. And then you saw an improvement in health-related quality of life and a reduction in symptom severity. So it seemed to be very sustained and consistent over time. And so this was really the first sham-controlled trial on tibial nerve stimulation. It provided level 1 evidence that it was effective. And then 36 months, data shows that it's sustainable with about 1 treatment a month. It is something that has been used a lot. What people probably can't glean from the trial is that at 6 weeks, you saw benefit in the active treatment group, but it really didn't meet statistical criteria until week 10 to 12. And so I always encourage patients to, don't stop at 6 weeks. I mean, continue with the 12 because it took that long to really separate out from placebo. Looking in the literature, there's been some meta-analysis done of tibial nerve stimulation, reviewing multiple trials, some randomized, some not, some comparative to antimuscarinics. And at the end, the conclusion was that, there's ample evidence to show that OAB symptoms are improved with tibial nerve stimulation. Looking at other disease states that we know may have an impact on this, the other disease states include fecal incontinence, and we know sacral neuromodulation works for that. But the trials on PTNS really haven't been consistent, and it may be that it's underdosed. It's something that we know with this, it's not as common to see on a daily basis. And so really, if there was some chronic stimulation, we may actually see a benefit, and I suspect we would. What about pelvic pain? We know sacral neuromodulation, there's lots of data on that for pelvic pain, although not approved for that. It can work very well for pelvic pain. And what we, if you look in the literature, there's mixed outcomes. There's some studies that were suggestive of improvement, some not. But, I still think there's an opportunity there to treat chronic pelvic pain. And then, but what's the problem? Well, the problem is time consuming. And these are patients who have the ability to come to the office once a week for 12 weeks and then once a month for, in theory, the rest of their lives. Although many insurance companies, for whatever reason, will quit paying after, after 2 years, which makes no sense because no other OAB treatment is that. But when we looked at our own data, we feel like we're doing it all the time. We have our nurse practitioners probably doing 6 to 8 of these a day. But when we looked at it, we found that patients on average completed about, 10 and a half, 11 treatments of their planned 12, that 89% completed at least 6 of the treatments. And that, about 71% of patients, which is what you would expect, again, looking at the data earlier, were improved at 12 weeks. But, interestingly, a fair number still continue to stay on antimuscarinic therapy. The other problem is the PTNS compliance over time. And what we found really is that of 82 patients that completed their 12 treatments, only 55% completed a median of 3 monthly treatments. And again, it feels like you're treating all these patients because there's so many patients with OAB, so there's always patients in the office having it done. But there's lots of reasons why this doesn't continue over time. And some is lack of efficacy, because this intermittent stimulation may not be ideal. And then you combine that with any types of cost and travel and stuff, it may have an impact. So what do we know? Well, we know PTNS works. We know that 12 weekly sessions is a burden. We know that there's not great long-term efficacy and limited compliance, and probably it's very much underdosed. So what can we improve? Well, we can improve if we can create a higher dosage, if we can have an implantable lead, if we make it office-based, patient-controlled, it'll improve compliance, improve efficiency, and then be easier and cheaper for the health system. So what's the rationale for chronic tibial stimulation? Sacral neuromodulation stimulates through the S3 nerve root, and we believe that neuromodulation works about afferent stimulation. And the role of afferent stimulation through S3 is just a single nerve root. At Beaumont, we had really developed and published a lot on pudendal neuromodulation, which is S2, 3, and 4. And what we showed is that pudendal worked better than sacral, and we do a lot of this. And in my mind, it's because of increased afferents. So could tibial be even better? Could tibial be, since it's S2, it's L4, L5, S1, S2, S3, potentially stimulating that chronically or more consistently could have a greater effect. And these are all things that need to be answered. But people are trying to answer this, and there's essentially 4 devices that are in active trial right now, and I'm going to touch on each of these devices. The one is Protect PNS. This is that Micron medical company that I work with. It's a small 7-centimeter tiny lead. Patients wear a wrap around their ankle. It's done in a minimally invasive fashion. I'll show you. There's the Blue Wind. This is done through a cut down. It's about a 4-centimeter cut down, where you open the fascia, you lay this on the nerve, sew it in place, and close it. They wear, again, an external device to activate the lead. You have eCoin, which is a fixed battery device. So it looks like a coin. This is just put underneath the skin above the fascia, and it can only activate the nerve like twice a week for 30 minutes to maintain some battery life. And there it's thought to be around 2 or 3 years. So it may be limited in its ability to be chronic stimulation and really have a difference in PTNS, but doesn't involve coming to the office. And then another company, StimRouter, which is approved for peripheral nerve stimulation right now, outside of outside of the tibial nerve, like for brachial plexus injury and things like that. And it is under trial also. So the eCoin has some data that's been presented and published, and this is an office-based procedure. There's an incision made and an introducer kind of dilator of underneath the skin, and this coin is dropped there. They presented on 46 subjects. They're around 60 years of age. Patients have to have this done, and then there's a number of weeks of delay to activation while this heals and sets into place. Again, it's automatically stimulated 2 times a week for 30 minutes. And they showed a 63% reduction in urgent incontinence episodes. Quality of life scores improved. There was a good safety profile. I think, looking at the PGII, which is like the GRA, I was just intrigued that of those that said they were much better or very much better, which are those 2 higher ends, together that was, only like 42%, where on the PTNS trial was a little higher. So patients maybe aren't perceiving themselves as well as the data looks, but I know there's active clinical trials ongoing right now, and that it'll be interesting to see. The Blue Wind, again, it's they presented some data. They probably have the longest data out there. It is an incision to put in, and they defined a clinical success as not just a 50% reduction in urgent incontinence episodes like a lot of people do, but it was that or return to normal voids of less than 8 per day, and on a 3-day diary. And what they showed is that about 71% of patients had clinical success. Over 25% became dry. They did have a little adverse events, but seem reasonable for an implant. And this also continues in phase 3 clinical trials. The stim router device is placed percutaneously. It has a little more complex implant technique. It's all minimally invasive, but because of the way you have to kind of run the wires, but it basically has a distal end with a single tying, proximal end, and then they wear this adhesive that sends signaling through to the lead, and it gets routed to the nerve. They actually have a sham control trial going on, which I think is very cool. And that sham control trial is something that we'll get to see more of and how that works out. And then, on the ProTech device, for us, it really became, how do we safely implant something at the tibial nerve? And as being urologists, we're not usually used to the leg anatomy. And, people were trying to do different implants in Europe, coming from the top down towards the tibial nerve in the leg. And so Dr. Searles, my partner, and myself, we went to our lab at Beaumont and we just started doing some leg dissections and realized what the anatomy showed and created a technique that we thought would work. And we actually wrote this up and got a method patent on it through Beaumont. So I'm going to just show you a short video of what we came up with. Let me go back up here. So let me just, I'm going to just start this video.
Directly behind the tibialis posterior and flexor digitorum longus tendons. This site is marked about 1/3 of the distance from the medial malleolus to the Achilles tendon. The tibia is palpated and marked to provide a directional vector for lead placement. 1% lidocaine.
Dr. Peters, it may be better if you dictate, talk it over yourself.
You're not hearing it? Okay, got it. So let me continue this. So essentially, I'm going to just back it up just a little bit here. Just again with the anatomy, this is the tibial nerve right here. This is an electrode that you see in there. These are the tendons. And what we found is that there is a position between the medial malleolus and the Achilles tendon that you could almost, in small ankles like this, you could feel the depression there, and that's where the tibial nerve is. And this is where we typically do a PTNS needle. But it's a measurable distance. And so if somebody with a bigger leg, you'll see in a minute, you can actually measure out. We mark the tibia here. This shows the trajectory of our introducer. We have a small lead introducer. We cut out a window so we can stimulate and we can actually see if we're activating the tibial nerve. We bend the introducer a little bit upward so that as we enter through a 6mm incision, what we're doing is we're gonna follow the trajectory of the tibia. So what we're gonna do is we're gonna pierce the fascia, and we do that kind of in a very controlled way, lay the hand down, and now we're below the fascia, right at the nerve, and we just advance this up. Once we advance it up, we can stimulate, and this is just showing another one, which is similar, but I'm gonna skip that one and just take it to a little bigger leg one here. So not everyone has those nice legs like you just saw. Some people have larger legs. So in that case, it's harder to feel that depression. So we're still marking the tibia bone, which is always palpable. But then we actually measured between the top of the medial malleolus to the Achilles, made that mark there, and again, pop through the fascia, lay it down, and advance. Through that little window that we had, and patients are just wide awake in the office for this. We just use some local anesthetic. But through that little window right here, we can then go ahead and we can touch with a hook electrode. This is showing a finder needle, but we just use the introducer these days. You can see the toe move. And then what we do is we have this lead and we just advance the lead, and inside of the lead is an integrated circuit so we can communicate with it. And we advance the lead, and then there's an external antenna and energy source that we can turn on, and you can see the toe move. And once we confirm that, we're seeing what we want, what we do then is we just deploy the lead like you would normally deploy a lead doing an interstim, and basically leaving the lead in situ, testing it one more time, making sure we see the same impact. And so you have the tines which prevent distal migration, and then we put a little subdermal stitch, and this is, so we create a little pocket down here, put a little redundant lead. We cut the lead, we put some PDS through the lead itself and through the dermis, and we just bury that knot, and then we just close it with a little steri strips, and then mark out where the antenna would be. So it's a very teachable and very easy approach that, you know, to get to the tibial nerve. And so our first experience with it was doing our first trial was more of a pilot trial, comparing that to PTNS. Patients got randomized to one or the other. They wore then, you know, a device. We actually had them stimulate about 6 hours a day, which was probably overkill. But for typical patients, right, that have OAB, they were randomized, and then we looked at the data. And what we found is that both PTNS and the chronic tibial nerve stimulation worked. But what we found is that those who received the chronic tibial nerve stimulation, you know, with the daily stimulation, that they achieved that 50% reduction sooner than you saw. It took the 13 weeks to see with PTNS. And so that gave us, you know, faith that, you know, that you can place a lead array. It also gave us some experience in a technique. We changed the lead, we shortened it, we made it more user-friendly. And what we found is the lead was stable, there was no migration. And so now where things are at after that pilot trial for this one is that we're doing a head-to-head trial versus InterStim. So patients are being randomized to an in-office tibial implant versus an InterStim implant, and it's a non-inferiority trial. And our intent and our hope is that we're going to see that this is equivalent to sacral neuromodulation, and if it is, it'll certainly give options beyond what we have. Because, you know, no matter what comes to market, and hopefully we'll have multiple things come to market, it can have a huge impact on quality of life. If you think about, in America, 37 million Americans suffer from overactive bladder. About 8.5 million are actively seeking treatment. We know that almost 90% quit taking drugs within a year because of efficacy and cost. And so we know it leaves a large group of people who still want treatment. But if you look at these millions of people who still want treatment, nationally, we're pathetic. I mean, we're treating probably 2 to 3% of patients with advanced therapies, meaning Botox, SNM, or PTNS. And there's lots of barriers to that. And there's barriers from a time constraint of coming for PTNS. There's concerns about, you know, retention in UTIs with Botox, you know, concerns about going to the OR and having something implanted with sacral neuromodulation. But, you know, if you actually had some tibial implant that can be done in the office, it would certainly lead to patient and physician acceptance. You know, it would lower the cost of care, you know, that won't cause a risk of retention, doesn't need batteries replaced all the time. You know, I really think what it can do is really allow us to treat more patients and improve quality of life, you know, not only in the United States, but you think about the worldwide population who are very limited in what they can do because of like cost of sacral neuromodulation. We can make something office-based and more affordable. I think it could have a major impact. And then we can look at things like fecal incontinence and pelvic pain and other things that it may benefit from once we have some implantable devices. So I'm excited that like the tibial nerve is the target right now, because I'm excited there's a number of products that are in play. And, you know, just to end, you know, I really think neuromodulation is changing the future of medicine. And I think the fact that the tibial nerve has so much afference going from L4 to S3, it can be very effective in treating OAB and other conditions. And I think that, you know, there are these limitations in what we're doing percutaneously right now, but if we can get some implants that are done in the office, make it cost effective, easily teachable, you know, and happy patients, then we're going to really, you know, change healthcare and really expand availability worldwide. So I think the future is really exciting around the tibial nerve, and I'm very excited to be part of all this too. So anyways, I will stop there and I will unshare my device here, and I appreciate everyone's time.
Hey, this is Howard. Can you all see my screen?
Yes.
All right, perfect. All right, so again, thanks for having me as well. And I'm gonna kind of follow up talking about sacral neuromodulation, but I'm gonna focus a little more on the role of MRI, and we'll kind of talk about in a moment why I think that's important at the very moment. oops, these are my disclosures. And so we're going to briefly go through sort of the official position regarding sacral neuromodulation and MRI, what the issue is, current and future developments, and really, does MRI really matter? So I'm going to take it as a given that sacral neuromodulation works and is a well-established therapy. It's been around since 1997. It's indicated for overactive bladder, for non-obstructive retention, and for fecal incontinence. And there are multiple studies that show excellent efficacy. And I would say, though I think a lot of what Ken just spoke about is very promising, and I think I agree with him on most of the points, but I think sacral neuromodulation really has the longest track record and would be called the gold standard. On the other hand, there are some issues. Historically, these devices have had problems with MRI compatibility, and after a few years, the battery needs to be replaced. Now, despite that, there have been many, many of these devices that have been implanted, and you can see, whoops, you can see there have been over 300,000 patients that have had the original device, which was the InterStim, implanted. So what are the issues from a MRI standpoint? And if you look at it, these devices have been MRI conditional, which means you can use it under certain circumstances. You can get an MRI under certain circumstances only for head imaging at 1.5 Tesla. And the reason for that is they're afraid that you may induce electrical currents that stimulate the lead. They're afraid you may shock the patient. They're afraid that you may damage the neurostimulator, and they're afraid of heating in the system that can occur. And the impact is that we have a therapy that we know works, and yet patients who may need an MRI in the future are denied this treatment, particularly perhaps neurologic patients. Also, patients who do have a device that's implanted are refused MRI. And in some cases, somebody who has a successful device but absolutely needs an MRI has to have it removed and then come back for a second surgery to have it replaced. And we have found that many actually never come back and get it replaced. So we had that question, and we decided, well, what actually happens when you remove these for MRI? So we looked at this a few years ago, and essentially what we found was that during the study period, we had 90 patients who underwent sacral neuromodulation device removal, of which almost a quarter of them were explanted because they needed an MRI. And interestingly, only a small number ever came back to have the device replaced. Now, in some of these patients, it may have been that it wasn't working as well, but in many of these, they had had a successful device. And that begs the question, once you have to get an MRI and have it removed, then people are fearful of having it done again, because who knows, they may need another MRI. So recently, there have been some advances, and the first solution that has really come out is a company called Axonics that recently introduced a system that is MRI conditional. So you can get full body 1.5 Tesla MRIs. It's also smaller and rechargeable. And this is just what the device looks like. So if you compare it to the current InterStim, it is smaller. Again, it is MRI conditional and it is rechargeable. So we recently published the 6-month findings from the multi-institutional study on this device. And this just shows the baseline symptom summary. So the average patient had between 5 and 6 urge incontinence episodes per day. And what we showed is that at 6 months, that had been decreased from 5.6 to 1.3 episodes per day. And interestingly, over 1/3 of the patients were completely dry, and 80% of the subjects had at least a 75% reduction in urge incontinence episodes. Now, when I look at this data, I would hesitate to say this is unique to this particular system. I think there are some interesting characteristics of the system, but I would suggest that in people who are expert implanters who really know how to do this and are using the latest techniques, these are really the outcomes that we should expect in the best case scenario for really all the sacral neuromodulation devices. When you define response by at least a 50% improvement in symptoms, you can see that 90% of the patients met that criteria and responded. And we now have data out to 1 year that's actually in press that you'll see soon that's very similar. When you looked at quality of life improvements, we had similar findings. Some of the characteristics, again, MRI approved full body 1.5 Tesla, and this was approved in the US about 6 months ago. Now, this is not the only technology out there that has come up with MRI solutions. Medtronic also has come up with a new device that indeed is a lot smaller than the current one, It's also rechargeable. And they actually have come up with a new lead. And it's interesting because the MRI issue is really one that's more a lead issue than the actual IPG issue. They have 1.5 and 3 Tesla labeling. And this was recently approved in Europe. So they've started using it in Europe. And we're still waiting in the US for the FDA approval, but we should see that somewhere within the next few months. So I think it's interesting that going forward with new implants, I don't think MRI is going to be an issue at all because these devices will be MRI conditional. The big question is, we still have hundreds of thousands of patients who have sort of the prior or the current, in some hands, device in them. And really, does this MRI stuff really matter? So the first question that we had, because we decided to look at this, because to me, it sort of killed me to see that we were taking out expensive implants in patients in whom they were working just to get an imaging test and then hoping they'd come back and redo the surgery. And when I weighed the pros and cons, to me, a minute risk of heating in a system, which has never been really shown, never been shown that any patient had any problems, and yet you're putting them through 2 surgeries, you're increasing the risk of infection, et cetera, it made no sense to me. So we decided to look at how much heating actually occurs. And per the FDA, a 2-degree increase is important because if it gets to 5 degrees for a certain number of minutes, then you can have brain tissue injury. But does that really pertain to the sacral area? So we first started with a phantom model. We published this a few years ago. And what we did is we took a plexiglass model of the head and torso. We filled it up with a gel. And then we put a sacral neuromodulation device, an InterStim, in exactly sort of the location you'd expect it in a human body. And then we did a lot of MRIs on it. And we did 3 different configurations. The full system with the IPG in the lead, a broken lead, as though you pulled the lead and it broke off, and a lead just by itself. And we ran it through multiple different MRIs, et cetera, et cetera. And what we ultimately found is if you have an intact system, you can see here, there's about a 3rd degree of temperature change. And I'll just go back here, say we had thermocouples at 4 different sites on each of these. So we measured temperature in multiple areas. So with an intact system, minimal temperature change. With a fractured lead, minimal temperature change. The only one that there was actually significant temperature change was in a lead by itself. And I think that's because this is a long antenna, so it picks up the energy, and then there's no heat sink, there's no IPG for it to be dispersed in. So our conclusions on this were that an intact device or just a lead fragment has very modest temperature changes. However, if you have a retained intact lead, that could be a problem. Our conclusions on this is actually probably a worst case scenario because we did lumbar imaging here. So it's really where the device is closest to the center of the coil. And also this model did not account for circulatory blood flow that could dissipate the heat. But the big question is what happens in a live person? So after we did this study, we then jumped through a few hoops with our IRB, and we did this study that was published just 2 years ago. So what we did is we recruited a number of patients who already had a functioning InterStim device, who needed either a lumbar or a sacral or a pelvic MRI. And we went ahead, signed them up, went through all the usual consents and everything. And then we actually had them fill out various questionnaires before and a month after. We checked the whole device as far as all of it's how it worked. And then we actually had a fellow in the room while the MRI was being done, just in case they had any discomfort or any pain, and to monitor all of those sorts of things. The bottom line is we enrolled a number of patients, and we found that there was no stimulation or discomfort or warmth during the MRI. There were no changes in any of the device function afterwards. And when we gave them questionnaires about their OAB, a month later, it showed nothing had changed in the sense that it was still functioning and giving the same relief as we had expected. So our conclusion at this point was that it was safe to perform an MRI in patients who have a traditional InterStim device. However, the radiologists, the MRI people who are very, very cautious, made us in the paper, it says on our specific machine, at our longitude and latitude, at our elevation. So they were super cautious. I think when you look at what's in the future, and the future really is now, is that we do have MRI compatible devices available. Currently, we have the Axonics device, which is 1.5T, and they're, I understand, applying for 3T as well. This is rechargeable. Medtronic has a 1.5 and 3T conditional device now in Europe. I expect it'll be in the US soon as well. People are looking at other things as well. This is an interesting device that sort of follows the idea of the implantable tibial nerve devices you just heard about, where actually just a small lead with a receiver is placed near the sacral nerves, and then a patch is applied over the sacral on the skin to actually send the energy to stimulate this lead. This one is still in early development, but I expect we'll see a number of new things in this area. So I think when we come to MRI and sacral neuromodulation, where are we? I think we now have a new device available in the US, and I expect we'll have more very soon that are MRI compatible. And this should increase the number of patients we have who can actually get these devices placed, allow for appropriate imaging studies when needed, and avoid the risk and cost of having to remove devices if somebody needs an MRI. I would conclude by saying sacral neuromodulation, I think, is an effective therapy for a number of indications. I showed you one study, which I think is sort of the best case scenario, but I think you can see that it clearly works. I think for patients who have the current devices, MRI is really fine. The problem is many radiologists refuse to image. At our center, with talking with radiologists, with having the patients sign some waivers, they are willing to do them in some patients. But the good news is that the newest devices that are coming out will be and are already MRI conditional, and thus we can use them. So I'd just conclude by saying that sacral neuromodulation, I think, plays an important role in the treatment of patients with refractory OAB, as well as a number of other diagnoses. And I just want to thank some of the various fellows and colleagues who participated and helped enormously with a lot of these studies. And with that, I'll turn it over back to you, Indy. Thank you.
Dr. Rodriguez, go ahead. Let's do a good 10-15 minute discussion, a case discussion. We have an engaged audience, and this is fascinating. So take your time. Larissa, you are muted. Yeah. Larissa, we cannot hear you.
Dr. Ginsberg is going to come up and present a case for the panelists. Go, David.
I'm working on it. Okay, people. You got me?
Yep.
Got you.
Okay. All right. All right. So first of all, Howard, Ken, Mike, thank you very much. That was really excellent. I appreciate you guys coming on board and doing this with us. So we're going to go with a really standard overactive bladder patient, 55-year-old woman. She's voiding every 1 to 2 hours. She's up 3 to 4 times a night to empty her bladder. She has urinary urgency urinary incontinence. She has failed trials of multiple medical therapies, including combination therapy with solifenacin and mirabegron. Examination is unremarkable. She has a negative UA. PVR is 42 cc, so it really is not going to be any as straightforward as that. So first question for our panelists. When you get a patient like this and you failed overactive oral therapies, do you do any further evaluation before saying, okay, time to go to one of these third-tier options that you all talked about? Howard, I'll call on you.
So I only do some further evaluation if I think there might be something else going on that may be causing these problems. If I think somebody might have obstruction, I mean, not this patient, but for instance, if someone had a little voiding dysfunction, I was concerned there may be some obstruction or something else going on. But I don't think urodynamics or most of these other studies have really shown to be predictive of outcomes with these. So if somebody has what looks like pretty straightforward refractory OAB, I have no problem proceeding without further evaluation.
All right, Mike, I'm going to ask you a question. I don't want to go deep into this rabbit hole, but let's say it was the exact same patient, but male, but really no obstructive voiding symptoms. So Mike, will you do a urodynamics in a male patient that has really just pure OAB symptoms, or you go right to the third-tier therapy?
So I usually like to look at a frequency volume chart and a post-void residual. So basically you can tell for a small volume void with good bladder emptying, traditionally that's going to be OAB. If they have larger volume voids with some residual, that may be an obstructive component. I think prior to proceeding on with therapies like botulinumtoxin, I would do a urodynamic test that looks specifically at that aspect. granted they'd already be on alpha blocker therapy, and if they're still having symptoms, then proceed with urodynamics.
All right, great. All right, so Ken, I mean, if we look at our three options, tibial nerve stimulation is by far and away the least invasive and less, the least amount of side effects. Is there anything additional information that I didn't talk about that might make you say, you know what, I don't want to do tibial nerve stimulation in a patient like this?
I mean, I think it's all just on, you know, based on patient preference. I mean, in a 55-year-old woman, you know, it seems like the average age of our tibial nerve patients are much older because they have time to just come to the office once a week and have it done. I mean, I don't think there's anything on history that would make me change anything. I think that tibial nerve, you burn no bridges, and it's a reasonable thing to try. And from a practice building standpoint in our practice, since we're a 40-person group, all of us see OAB, even though a lot of them are oncologists. And it's very easy for them, if they've already been on meds, to say, go see the nurse practitioner and get PTNS. And if that doesn't, if the patient's willing and it doesn't work, then they get referred to one of us to do, you know, Botox or SNM. So, I mean, I think it's a reasonable transitional thing, but there's nothing in particular that would make me not do it.
Right.
I just want to mention in the chat, Dr. Dawam just mentioned that in the UK, they don't do any third-line treatments without urodynamics, just for the audience. And
Okay.
can I ask you a question? What you do with the diabetic that has maybe neuropathy or decreased sensation, the like, do you care for the PTNS?
So there really isn't any good data to say whether they're impacted at all. I mean, since this is about afferents and, you know, they may not feel it as much. I mean, you usually will still get a greater toe movement. I mean, I mean, a lot of our older patients have some underlying neuropathy, and they, you know, perceive themselves as better. So, you know, it wouldn't make me not do it.
All right, so Ken, so she gets 6 weeks of PTNS. You spoke to this a bit on your slide. She's only mildly improved. So you said you would continue. So maybe can you give some ideas of what you do to help keep that patient on, first to get them past that 6 weeks? Because we always have patients after 6 weeks are like, I don't want to keep coming, it's not helping me. And then also maybe speak to what you do to keep patients on long-term that do well, because we do see drop-offs over the course of time. And are there any tips to picking that right patient who really may be that optimal person?
Yeah, so I mean, I think the 6 weeks it really is about your initial discussion with the patient. And I think because a lot of insurance companies have us reevaluate patients at 6 weeks, and we have to document there's some benefit, there's really no evidence in the literature that 6 weeks is any magic number. And like I said, when you really compared when we separated from sham, although you saw improvement at 6 weeks in both the sham group and in the active tibial group, it wasn't until week 10 that they actually statistically separated. So what I tell patients up front is, I tell them that. I said, look, you might see some benefit at 6 weeks, but really the data suggests it's, you know, 12 weeks that you need. So I encourage them right from the very beginning to continue. I know talking points are different in some places. A lot of people say, well, we'll see how you are at 6 weeks and decide. I think once you do that, you lose more patients. You know, if you get them to the 12 weeks and they're better, I mean, that's really going to define whether they're going to keep this program going on long term. The problem is, again, it's an insurance thing. You're allowed to do one a month, and some patients need it more often than that. There's some patients within 2 weeks, they're already having symptoms coming back, but they can't get it paid for. And there's some people who can go 6 weeks and not need another one. So that's part of the problem. And I have some patients who will pay for an interim one cash just to be able to maintain themselves. But I do think it gets frustrating for patients over time to keep coming back and to, you know, and that 1 month may not be the perfect things for them. And as far as the right patient, it's got to be that patient who just, you know, has the time to come to the office and is willing to in their crazy lives that we all have, willing and able to do it. And to me, it's like I love it for a 75, 80-year-old in my office who, you know, they like coming and chatting and spending some time with our nurse practitioners. But, you know, this is where I think if you had an implantable, it would be something where it's a one and done. And, you know, this type of patient you just described, it would be a perfect candidate for any of those 4 clinical trials I mentioned, because this is the index patient we'd want in those.
So Ken, do you, when we have an implantable tibial nerve stimulation device available, do you think you're going to be using any percutaneous tibial nerve stimulation anymore?
No, I think it'll completely replace PTNS, and it would be really hard pressed to use Botox, because why would I put them at a risk of retain? If it works, I mean, let's say it does work as well as sacral neuromodulation or near it, you know, and it's office based and it's minimally invasive and it can be done right, you know, with just local anesthetic to the skin. You know, why would I ever do Botox in somebody again with the inherent risk and having to repeat it? And for sure, why would I go to the OR unless they have giant ankles and I just can't put in a device? You know, why would I do sacral neuromodulation? Now, maybe if they had fecal incontinence, and we've shown that tibial doesn't treat that, but I think it will. You know, you can make those kind of arguments. But, you know, if you really think, it could be kind of really transformational on how we manage patients if we have, and, you know, physicians like doing office-based procedures. And so it's a good thing for the practice. It's a good thing for the patient. So.
All right, so let's move along.
Dr. Peters, question. This is Giovanni. How do you think about the efficacy of PTNS versus oral medications for OAB? Like, do you think of it in terms of adherence? Because adherence to oral medication is certainly worse than it is to PTNS. What about efficacy symptom-wise?
Well, so there are some studies. One's called the Orbit trial, which was, you know, PTNS versus, I think, tolterodine. And basically it showed that if you look at objectively, patients perceive themselves, you know, I mean, patients had a similar reduction in frequency and incontinence on both of them. So they were equivalent to each other. But then if you looked at patient satisfaction, or like the OABQs and the GRAs, patients perceive themselves better with PTNS. So although objectively you may see they're equal, I think subjectively patients with neuromodulation in general, it helps with other secondary gains, and I think that it's a better treatment. I'd like it to be like, I'd like to be able to do that instead of drug. We know all the issues with drugs. We know most people quit taking them. The whole issue with dementia and all that right now is a concern. So it'd be nice if you could just do PTNS as an initial treatment.
That actually was going to be my follow-up question in regards to, you know, there are people that say maybe we should be changing our guideline and looking at PTNS at maybe the same level as oral medications or before oral medications, because we don't have issues with dry mouth, constipation. There's no potential warnings of cognitive decline, dementia, things like that. Certainly it's not there now. We'll see if that ever goes in that direction.
Yeah, I agree.
Yeah.
Ken, what kind of maintenance do you do and for how long?
I mean, you know, we do what we can get paid to do, you know, which is once a month, and we do it as long as the patient's willing to do it, or 2 years. I mean, insurance companies, most of them will quit paying in 2 years, which is, again, ridiculous. But, you know, we really try to encourage patients to come back once a month for this. But it's sort of like any other OAB treatment. You know, you can lose these patients. Like if you had some type of nurse navigator in your office who kind of follows these patients and stays in touch with them, because people fall off because something happened, they missed an appointment, now they've lost that ability to have that one, and now they're worse. And so maybe just one single treatment isn't going to make them better. It's complicated. So it's about really trying to help kind of guide them through the process. And I see on your slide now, the question is if they're still being bothered after doing this, you know, what would you do? And, you know, I mentioned like 30% of patients, at least in the trials, were still on some type of medication for the OAB despite PTNS. And I usually have them stay on the medication while we do it. And then I try to stop the medication, if, you know, between that 6 and 12 week period and see how they do. But, you know, certainly if they're still bothered, I would move on to something else.
All right. Well, then let's move on. So she doesn't have an optimal response to PTNS, and we're now choosing between sacral neuromodulation and botulinumtoxin. So Mike and Howard, you guys talked about that. What are the factors that may make you lead towards one, or make you lean towards or away from either of these options? And I put up a variety of issues that may or may not impact your decision-making process. So I don't know, Howard, you want to go first, and Mike, want to follow up with that?
Sure. So I think, I mean, as everyone has alluded to, I think all of these have a role and all are good options. But I think when it comes to sacral neuromodulation, there are certain patient characteristics, some of which are listed here, that would lead you to perhaps prefer it over botulinum toxin. So something like if they also have bowel issues, because it's been shown to help FI, and in some other countries, it's actually used for other bowel disorders. If somebody perhaps has poor emptying, so they don't have any urodynamic evidence of obstruction, but they're just not emptying well. And we know that this can help patients with emptying issues sometimes, whereas I wouldn't want to give Botox to somebody who's already not emptying well. So there are clearly a number of reasons that I might prefer one over the other.
Mike?
I would just add that obviously these are all things to consider, but the one thing about overactive bladder, remember, these are not competitive therapies. It is basically multimodal therapy. Patients still should be doing lifestyle changes, behavior therapy. Many of them are still on medication therapy. And then utilization of these technologies. Granted that I think sacral neuromodulation therapy is basically an afferent aspect, whereas botulinum toxin has mainly efferent with afferent components to it. So understanding how they can work together or separately and which order you do them in is not really as critical as kind of getting to the patient's ultimate goals.
So Mike, you bring up a good point about patients being on oral therapy often when we then go into one of these third tiers. How do you try to manage those medications and try to, I mean, it's almost easy to forget. You give someone neuromodulation and then, oh my gosh, you're still on that oxybutynin, you're 85 years old, we want to get you off of that. So what is your strategy with that?
All right, so my strategy depends, once again, are you dealing with urgent continence trying to fix that, or is it urgency? Depending what the parameter is. Urgent continence is what most of these are really for. So if someone's already on medication therapy and antimuscarinic and a beta-3 having no side effects, maybe like this patient, but not having clinical efficacy, I would actually perform one of these modalities. And when they get their goal, with the understanding with the patient that once you get there, we'll start weaning you off those medicines. But the point is, most of those medicines take quite some time to get up to speed. Granted, they may not want to be on them, but they haven't met their goal. So for example, if I'm using botulinum toxin, I still would inject while they're on the medicine, see them back at 2 weeks, assess their PVRs, assess their symptoms. If they're doing well, obviously wean off the medicine. And I do that the same with neuromodulation therapy. You know, patients want a monotherapy. I get it, I understand it. But the realities are the chances of a monotherapy really helping them are in the 30 to 35% range.
Great. Well, let's move on. So she likes to proceed with sacral neuromodulation. So Howard, for a patient with overactive bladder, with urgency urinary incontinence, what are you telling her a chance of success is? And I guess part of that question is, what do we define as success in this patient population? And how long of a trial is your test stimulation for this patient?
So I think if you look at the trial that I mentioned in my presentation, this is exactly the sort of patient that was a candidate for that trial. And in that trial, defining success as at least a 50% improvement in their symptoms, and primarily urgent incontinence was what was being looked at. The success rate was about 90%. So I think that was a best case scenario situation. But in my hands, and I think in a lot of people's hands who do a lot of these, I would tell her that her success of significant improvement, which is going to be over 50%, is above 80% in this particular setting.
So when you say in your hands, so what we've learned things over the years in terms of optimizing your stimulation. So maybe give listeners a couple of tips in terms of how you really optimize lead placement to get an optimal outcome for sacral neuromodulation.
So I think the idea is that you really want ultimately to get the lead as close to the nerve, and you want as many of the electrodes to be close to the nerve, so you have more options in the future, number one. And number two, the closer to the nerve, theoretically, the lower power will be settings will be necessary, and therefore you'll have a longer battery life if you're using an actual battery. And there have been a number of studies that looked at this. So some of the things that we've done, most of us are probably using the curved inserts in the leads, which allows it to follow the track of the nerve a little better when you're putting this in. I think probably everybody, at least for the final stage of putting the permanent device in, is using fluoroscopy. So you can actually see exactly where you are and get a sense of what's happening. And we're trying to really get the leads placed such that we're able to get stimulation really at all the various contact points with as little energy as possible. Now, I'm aware that there are some other studies that have shown that even in cases where the lead placement is not perfect, you can still have very good results. But I think in general, it makes sense that using some of these curved stylet for the lead and really getting it as close as possible with the ability to use all the contact points makes a lot of sense, and it has contributed to these sorts of success rates.
Thank you.
Can I make a comment? Just because so much of this is about talking points with the patient. And although we, from an insurance standpoint, consider success at least 50% better, it's really important that we know what the patient's goal setting is, because if that isn't clear to them, we're like, oh, look, you're doing great, you're 50% better, but that isn't what they wanted or anticipated. So I think it's really important up front patients understand that that's a minimum improvement we need to see. You know, I always tell patients, many patients get 80, 90% better, but I tell them it's hard to make anyone 100% better, but it can happen. And, the best thing is they could kind of test drive the car before they buy it and see what it really does for them. But I think just really making sure that they know up front what all these therapies are and their limitations, I think really makes it easier for the patients then to make informed decisions.
So that's a superb point, Ken, in terms of us managing patients' expectations. So you talk about having the patient give a test drive of the car. So that's my second question. So when we first started doing this, the paradigm was we do a 1-week test stim for urgent continence and a 2-week test stim for more of urinary retention. I essentially do a 2-week test stim for everybody. I'm interested to hear what the panel says. So maybe the three of you can just let me know how you manage your period of test stimulation for these patients. Ken, you're on the screen. What do you do first?
Yeah, so, I don't do any P&Es in the office. I'm one of the people who published a paper years ago showing we had about a 40% test implant rate with a P&E, and it was like 90% with a stage. And I always like the fact that if I put a lead in, patients get to feel and know what it does. It's the same lead they end up with, because I've had times in the past where I did a P&E, patients did great. Then I put the permanent lead in and they're like, well, that's not where I felt it. That's not what it did. So I'm a staged person. I stage everyone for 2 weeks. I will extend it an extra week if there are circumstances to say I should, because maybe the patient had some tough recovery or, symptoms maybe just starting to get better. So I'll go 3 weeks. I've gone as long as 4, but across the board, 2 weeks is kind of my standard I try to stick with.
How do you manage the risk of infection when you have a trial period that's longer than a week and a half?
I don't think there's any increased risk of infection. I mean, I certainly haven't seen it, and many of the publications, contemporary publications you see now are, 2-week trials, and they're very, low infection rates. I think as long as, how we do this and covering them with some perioperative antibiotics, I don't think it increases the risk significantly.
Yeah, I would agree with Ken. I mean, so when I do a staged one, my standard is 2 weeks, but often till we get them back to the OR to put the IPG in, and maybe 3 weeks. And as Ken said, if after 2 weeks it's still not sure, then we will extend it. I happen to do a lot of P&Es. I think we found that we use fluoroscopy, and our conversion rate, and really what's more important than conversion rate is how the patients are doing a month or two later, is higher than in some of the earlier studies. But with the P&E leads, the traditional teaching was within a week it starts to migrate. And I've been surprised that, how many patients by day 2 or 3 are telling you this is a home run, I want to proceed. There's a new P&E lead that Medtronic recently introduced in the US that, because of the way it's constructed, it should have a lot less migration, so that it'll really open up the opportunity if you want to even keep that in perhaps for 2 weeks or more. But I don't think there's anything wrong if you're not sure to keep the lead in a little longer, because the last thing you want is a patient where you're unsure during the test phase and it kind of was better and it kind of wasn't. And in my experience, the ones who are hesitating and, yeah, I think it's better, but I'm not sure if it's better, those are the ones that in general, if you go ahead and implant them 3 months later, they'll be in your office telling you, well, it never really worked and it's not working now. So I like during the test trial phase for the patient to be happy and really feel that there was improvement to go on to the second stage.
And one comment I would make is that, during the Axonics trials, there was no test. They went strictly right to the operating room, and based on the optimized technique of placement, there's a 90% success, greater than 50% improvement. So it really questions the value of needing a test if you can optimize the intraoperative settings. Yeah,
I'll just mention there was an article in the Journal of Urology, I think last month, where a group from Kaiser, I think, sort of did the same thing, where if they got a good result on the test in the OR, they went ahead and put the entire thing in. And similarly, they had a very good overall outcome.
All right, so I know Indy's saying we're short on time, so we're going to move this up. So you kind of already answered this, Howard. Do you have a patient that does okay, but doesn't get that 50% improvement? And they say, come on, doc, I know you put the implant in, I'm going to be better. Your answer to this patient is?
I'd say let's give it another week.
And she comes back another week and it's the same?
So I'd have to see what her expectations were. There are some patients who things are horrible, and if they have 40% improvement, that's great for them. So at the end of the day, I'd have a long talk, and based on really the expectations, I might move ahead, but this is one that it would take a long discussion with the patient for me to go to a full implant.
Right. I mean, I think the thought is, what you said, I think is an important point. The patients that usually do well are those that really come back and say, wow, this was a great 2 weeks, and they're going to do well. When you're on that fence, it may not be the optimal long-term outcome.
But just real quick, that's why I use the GRA for the sacral stim all the time. And if someone says they're moderately or markedly better, that captures it better than a diary does, because it doesn't tell you that sense of urgency or that concern they're going to leak when they're out and about. So I really use what's a patient's perception, and then use these numbers as a secondary thing. So if the patient really feels like it's impacting them, I'll document that and plan them.
Great. All right, I'm going to go to my last slide here. So let's say she ends up getting botulinumtoxin instead. Mike, you touched upon some of this. Dose, number of injections, dilutions, templates. I think we've all been intrigued by this template where we're going more in the trigone. So how are you deciding where you're putting your needle now when managing patients like this?
Right, so this specific patient, she's got pretty refractory urge incontinence, been on all those types of medicines, failed various different therapies. So for her, I'm not really concerned about incomplete bladder emptying. She's not diabetic. She's not age over 70. So I would actually do these sort of a standard template that was done, basically still utilizing 100 units. I would include the trigone, but also kind of spread it out in a more diffuse location. Remember, the data that I showed regarding the LOBOT trial was really to try to decrease the risk of need for catheterization. The results, although they were good, once again, they're not as good as the original phase 3 trial data. So for her, I would go back to that. Now, as I say, if there are patients who had concerns for incomplete bladder emptying in those some at-risk groups I talked about, that's where I think that template comes in.
All right, so she comes in, and before you're gonna do the injection, you get a urinalysis, and there's some white blood cells in the urinalysis, a few bacteria. She has no symptoms of an active urinary tract infection. So how do you, I'm interested to hear how everyone on the panel handles their antibiotic regimen, looking for potential infection, dirty urine when you're gonna do a Botox injection.
So what I tend to do is just like this. She comes in at that point in time, she gives a urinalysis, but at the time of catheterization, that's when we repeat the urinalysis and double check it because of urogenital atrophy, specimen collection methodologies could be different. Additionally, we would give them an antibiotic at that time, which they're totally asymptomatic. Even if the catheterized specimen had white blood cells, I would actually still proceed with cystoscopy. I would not open up the Botox at this point in time, look at the urothelium, and then proceed on.
All right.
I can't,
apparently we have no time. So I'm going to go to the last question, which is, she comes back 2 weeks later, Mike. She's super happy. PVR is 370. How are you handling that?
So I acknowledge it. I tell her that it's worked. She's got elevated residuals, but as long as she's asymptomatic, let's follow this out. I may do telephone follow-ups with her in a week to 2 weeks. If she has any obstructive symptoms, any concern, she should come back. And at that point in time, we discuss options and need for catheterization.
Awesome.
Thank you so very much to everybody. This has been a great session. I'm really, really happy that you were able to join us. We had a number of questions that we've been answering in the chat room as well as comments while you guys were talking. So there's a lot of interest, and we'll hope to have you back soon for some other sessions. Dr. Gill?
Thank you.
Thank you. Thank you all. Thank you, Dr. Kennelly. Thank you, Dr. Goldman. Thank you, Dr. Peters, for an outstanding presentation. Thank you also to the home all-star team, Dr. Rodriguez, Dr. Ginsberg, and Dr. Craden. Really enjoyed the conversation. And so just want to say, Gio, can you put up the last slide, please? Just want to say to those that are still out there listening that all the videos of our 60 Minutes programs are available on the YouTube channel that the department has created, USC Urology. You can see it on your screens. Some excellent stuff there. But also, more importantly, I want to say that we plan on continuing the 60 Minutes format, hopefully even in the post-corona days. We may change the timing a little bit to make it more feasible given our busy work schedules. But also there is so much interest that we may be doing some additional 60 minutes here or there over and above the Thursday only format. So once again, thank you, Ken. Thank you, Mike. And thank you, Howard. Great job, guys. Stay safe. David, Larissa, Evgeny, 2 thumbs up. Excellent job.
Thank you all.
Thank you. Bye-bye.
Thanks, guys.
Bye-bye.
Thank you.